We're on it. All right. So we were discussing the endocrine system, and at the very end, we learned about the hypothalamic pituitary axis. So that's where we left off. We discussed that endocrine glands or tissues don't release hormones just to say, hey, what's up? They do it only when they're stimulated to do so, only when they need to. And we learned about the 3 stimuli. They can either be responding to a critical element in the blood, something calcium or glucose, and if the levels are high or low, then you get a release of a hormone to control or restore homeostasis. Sometimes some glands are innervated, so it's going to be a nerve stimulus that causes them to release their hormones, or other times it's actually going to be another hormone that causes it to release its hormones. So I was setting up this analogy for you about the hypothalamus being the captain. It is connected to its first mate, the pituitary gland, by a stalk called the infundibulum. There's 2 parts to the pituitary gland, and we're going to call the pituitary gland our first mate. Like I said, just totally analogy. And there's an anterior part and a posterior part. So the posterior part, let me flick off the lights for a minute, is called the neural hypophysis. And like I said, I'm not really going to ask you that word, but there is a neural connection between the hypothalamus and that posterior pituitary gland. So they're showing you these are neuron cell bodies because the hypothalamus is part of the brain. And what this connection between the hypothalamus and the posterior pituitary, the hypothalamus makes hormones. Like I said, as a captain, the captain can do something itself. And so it makes 2 hormones, oxytocin and antidiuretic hormone. It makes those hormones in different regions. They're called nuclei. And then it sends those hormones down those axons, and then those hormones are stored in the posterior pituitary gland. So the posterior pituitary doesn't make anything. It is just a storage shed. It just holds on to those hormones until the hypothalamus sends down an action potential, bzz, and then it releases either ADH, antidiuretic hormone, or oxytocin, depending upon what's going on. So there's a neural stimuli. So kind of you can remember the difference between anterior and posterior. If you have a storage shed, you want to keep your lawn equipment, you don't put that in the front yard, right? You put it in the backyard. So the posterior pituitary is really just a storage shed for the hormones made by the hypothalamus. So the 2 hormones made by the hypothalamus released from the posterior pituitary, one is oxytocin, and I wore my shirt, and if you came in late, we were having a whole conversation about oxytocin, but we're going to have it again. Oxytocin has many functions in the human body. One very important function is to facilitate labor and delivery. And in AP1, if you learned about positive feedback loops, this was your example. There's really only 2 good ones. And so late in pregnancy, when the baby's head pushes on the cervix, so this is the uterus, the womb, this is the cervix. When the baby's head pushes, that sends a nerve stimulus. It's transmitted to the brain. The hypothalamus goes, okay, we've got some labor going on. We've got some pushing. So then a neuron signal from the hypothalamus, posterior pituitary, release oxytocin. The target for oxytocin in this case is going to be the smooth muscle of the uterus. So now we get uterine contractions. So now that baby's head is going to be pushed against that cervix, which is going to cause more muscle stretch, which sends that signal back to the hypothalamus. Hypothalamus goes, we've got stretching. Okay, neuron signal, posterior pituitary, oxytocin, and it just keeps going until that baby is delivered. Other things, we learned about permissiveness, and we said prolactin and oxytocin. You have to have prolactin and oxytocin in order to get lactation. So milk letdown, you get a release of oxytocin. Also, pleasurable smooth muscle contractions in both males and females during orgasm are caused by oxytocin. Oxytocin is our human bonding hormone. You can also get oxytocin if you you have those deep conversations with somebody, you're really just connecting, you're looking someone in the eye. You got a little oxytocin there. Your dog makes oxytocin. Your dog ever stare at you? Does your dog ever stare at you? Sometimes it's like, hey, you got me? Okay, they make oxytocin too. So that we are designed to bond to whatever is before us when we have a release of oxytocin. We were talking earlier that you missed that. Maybe that's broken in society. Yes, we know that orgasms don't always bond people to that person in front of them, but that bonder gets broken. But think about it in labor and delivery. That hurts a woman. It's kind of painful. So it's kind of good to have this rush of oxytocin. So then as soon as the baby's born, you're like, oh my gosh, I love this baby so much. Right? It's a good thing, or we wouldn't be here. Also, baby wakes you up. You have to feed it. Good thing to have a rush of oxytocin, right? You go, oh, I love this baby so much. Because if mothers didn't love their children, where would we be? Dead. Okay, we'd be dead. Think like evolutionary saber-tooth tiger. Yeah, take it. It wakes me up all the time, right? Okay, so that's oxytocin. The other hormone made by the hypothalamus, released by the posterior pituitary, is ADH, antidiuretic hormone, also called vasopressin.
Hormonal communication generally begins with a part of the neuroendocrine system receiving sensory information and reacting by issuing a command to the body in the form of a hormone. In this example, dehydration is detected by osmoreceptors in the hypothalamus, which then directs or stimulates the posterior pituitary gland to release antidiuretic hormone, ADH. The next step is to transport the hormone molecules to target cells. This is typically done via the bloodstream. Here, ADH is transported through the bloodstream to the kidneys and blood vessels. When hormone molecules reach target cells, they will bind to matching receptors on those cells, and the hormone receptor complexes will trigger changes in the target cells. This causes the kidneys to reduce the urine volume output, thereby increasing water retention and countering dehydration. In blood vessels, vasoconstriction is increased, leading to higher blood pressure and thus countering the blood pressure drop caused by dehydration.
Okay, so anti-diuretic hormone. So if I'm anti something, what does that mean?
Against.
I'm against it. Diuresis is urination. So this hormone is against urination. There are osmoreceptors, and you're going to be hearing about ADH for the next 3 units, by the way. So this isn't going away. First pass at it. So if you get it the first time around, it makes it easier for Unit 2 and Unit 3. So there's osmoreceptors in the hypothalamus, because he's the captain. And so always just kind of taking inventory, how salty are we? Are we dehydrated? Because if you lose water, you get more solutes. Okay, so that just kind of says we're a little dehydrated right now. Other things too, there's a connection between blood volume, the amount of blood in your vessels, and your blood pressure. So a drop in blood pressure also is going to stimulate this. So we get ADH, there's 2 targets. One is the kidneys, so the kidneys are going to reabsorb more water, so reduce urine output. The other one is the blood vessels. Blood vessels, when they constrict, raise blood pressure. Evolutionarily, we had a hard time getting water. Think about it. Okay, so we were more in danger of dehydrating and suffering from low blood pressure than high blood pressure. We don't have that problem anymore, so what's a big problem in our country?
High blood pressure.
Exactly. So this is why. So we've got a whole bunch of things to raise our blood pressure. We only have one hormone to lower it. We'll talk about that in Unit 2. Other things too, it stimulates our thirst center, which is also the hypothalamus. So cue thirst, so we just go to seek water. And so that's how this functions. And if anyone drinks alcohol, how's your urination habits when you're a night of drinking? Frequent. There you go. Thank you. Yes. It inhibits antidiuretic hormone. So a lot of times the next morning you feel kind of crappy. A lot of it's because you're dehydrated. The other thing too, we release more at night. If you urinate frequently at night?
Yes.
Okay. Well, I'm supposed to say no. But
Oh, like 5 times a night is horrible.
oh, I'm so sorry. Okay. Usually you urinate more during the day and you kind of sleep through the night, maybe you get up once. Okay, but you have we have circadian rhythms to some of our hormones. All right, I see my animations. So for this, we always going to talk about where the gland, the hormone released, the target, and then imbalances. Okay, so let's say if you had too much antidiuretic hormone, right? So hypersecretion, they call it syndrome of inappropriate ADH release, which I think is just a mouthful and kind of a dumb name, but we're going to go with it because they didn't ask me. So if you have too much ADH, are you peeing or not peeing?
No.
No pee. There you go. So not peeing. And so now you might be holding on to too much fluid, okay? So if you have too much fluid, your body can swell, but a place that we don't swell well is going to be the brain. Okay, so that's why I gave you this guy. I pulled it up. I'm not even sure what, I think it's from an old Star Trek. Okay, so if you have swelling in the brain, headache, seizures, coma, death. Okay, that's depending upon how severe it is. So treatment is going to be, they have to really monitor their sodium and water kind of tied together, so monitor sodium levels, fluid levels, and they just have to really make sure that they don't hold on to too much fluid. As opposed to the opposite, which is called diabetes insipidus, and now you have too little ADH. So now you can't conserve fluids, so I have to go pee really bad, so peeing all the time, and then but always being thirsty because you can't hold on to your fluids. Okay, so high volume dilute urine. Usually comparing the two, I'm not saying this is fun, okay, but comparing the two, this is less serious. Because if someone's conscious, then you just have to drink more. Just hydrate, don't forget to drink more water, as opposed to, seizures and coma and death. Okay. Diabetes insipidus, that name, so diabetes means to flow through. When people have diabetes mellitus, type 1 or type 2, they urinate frequently if it's not being treated. Okay, this one, so back in the day, they didn't have a glucose monitor test, so they would taste the urine. And in this case, it's very much like water, so it was tasteless. I know, Shalanda was like, gross! It was tasteless, so that's what insipid means, you can't tell something is there. So that's where that gets its name. Okay, so now we're going to color. So this is your first color sheet, and the whole thing is either color-code it somehow or attach it to the structure. And this is a good review sheet. When I was in school, I'm a picture person. And I would, we had textbooks back in the day. Yeah, had to buy them. I would write all over the figures. And so that's kind of how I process things. I realize you may not like to color. I'm not grading your coloring. It's more the process of doing it. So find your hypothalamus. And so it'd be right here. So this is a blow-up of this brain region right here. And so attach it, color-code it, just so I know you know where it is, and so you'll know where it is later when you look at it. So remember, we're calling hypothalamus the captain. That's just an analogy. It is the integration center for homeostasis. Captain. It is the link between the nervous system and the endocrine system. I'm going to ask you that. It talks to the pituitary gland. It talks to the anterior pituitary, which we'll cover shortly. And then it is linked to the posterior pituitary by a neural connection. The hypothalamus makes two hormones, anti-diuretic hormone, also called vasopressin. Vaso means vessel, press means to constrict, and so that's going to help us hold on to water, so that arrow up, just increase water retention, and it helps us to increase blood pressure. You go ahead and color your posterior pituitary. The other hormone that's made by the hypothalamus that's going to be stored in that posterior pituitary is oxytocin. We said that's uterine contractions, milk letdown, you can write human bonding, orgasm. Usually people remember those two. I don't know why. So it's a neural connection, so neural stimulus to release those hormones. The imbalances, if there's too much ADH, syndrome of inappropriate ADH release, SIADH. If there's too little, so hypo means below, then it's called diabetes insipidus. It's like I said, this is just kind of a quick study sheet, so if you want the rest of the story, you can look through your notes. Okay, so the anterior pituitary, so we're calling the hypothalamus the captain, the anterior pituitary is the first mate. Okay, they have a vascular connection. It's called a portal system, so it's called the hypophyseal portal system. And when we discuss the cardiovascular system in the next unit, normally it's arteries, arterioles, capillaries, venules, veins, back to the heart. In this case, we have a capillary bed between two veins. So it's unusual. So they call it a portal system. It just means that since they're speaking through hormones, if hormones travel in the bloodstream, it's just a shorter connection, so it immediately goes to the anterior pituitary without kind of being diluted out and going to the body first. So they just have this vascular direct connection. The hypothalamus can't use words, but it's going to use hormones. And so it's going to use releasing hormones or inhibiting hormones. So either go signal, I'll put it in green. So releasing hormones, or sometimes the signal is to cut that off, like we're done now, or inhibiting hormones. The captain is kind of a snob. He only talks to his first mate, okay? So this order never changes. So the hypothalamus is never going to go over here and talk to the thyroid gland. Never going to happen, okay? So it's kind of, we have this chain of command. So it talks to the anterior pituitary, and then the anterior pituitary is going to listen to the directions, so perceive that message, and then respond accordingly. So let's kind of take a look. Since these hormones are causing another gland to release their hormones, they're called tropic hormones. That word tropin means to move. So these are, let me find another color. What did I not use? I didn't use blue. Tropic hormones. Okay. So just as some examples, so if the hypothalamus wants something to happen, wants one of the endocrine glands to release their hormones, it's just called blank releasing hormone. Okay, so thyrotropin releasing hormone means release that tropic hormone that's going to get the thyroid going. Prolactin releasing hormone, you get prolactin release. Growth hormone releasing hormone, you get growth hormone release. Gonadotropin releasing hormone, you get gonadotropin. Okay, kind of get that. If they want to shut something down, then it releases inhibiting hormones. That's it. So prolactin inhibiting hormones stop making prolactin. How these are going to be controlled is through that negative feedback loop, so kind of like your thermostat, right? So when the temperature is just fine, the air conditioner is off. When it gets too warm, the AC kicks on and brings it back down. Okay, so just negative feedback loop. And it kind of makes sense. If the orders are carried out, then the hypothalamus doesn't need to send the orders anymore. So kind of like, you know, so if the deed is done, the message is no longer necessary. So I gave you this in your notes, and this is just how I remembered it. The anterior pituitary makes a lot of hormones, okay? So I gave you a mnemonic, so flat, F-L-A-T, and then PG. So F stands for follicle stimulating hormone, L stands for luteinizing hormone, A stands for adrenocorticotropic hormone, T stands for thyroid stimulating hormone. All four of these are tropic hormones that are going to talk to the other endocrine glands and tell them to do their job. Because remember, we have like a chain of command. Okay? The other two, prolactin and growth hormone, those are hormones on their own right. They're not tropic hormones. They're actually going to do stuff. So we have releasing hormones, and then tropic hormones, F-L-A-T, are going to be released, and then those are orders for the other endocrine glands. So F and L, I'm just introducing them. We will talk about those when we get to Unit 5. They have to do with reproduction. So F and L are messages, they're gonadotropins, for either the testes in males or the ovaries in females. From follicle stimulating hormone, in women we get egg production, and then we get sperm production. Luteinizing hormone, we're going to get estrogen, progesterone in females. In males, we get testosterone. That's kind of all I'm going to say about that. They're tropic hormones to the gonads, and they cause something to happen. We're going to talk about ACTH. We're going to talk about thyroid stimulating hormone shortly. So let's talk about growth hormone. What do you think it does? Isn't that great? It's kind of nice when they name things well. Okay. So the release is going to be controlled. because it doesn't do it just because it's Friday or Wednesday in our case. So growth hormone releasing hormone, anterior pituitary gland releases growth hormone. Okay? The amount released is going to be impacted by age. You release more when you're younger as opposed to when you're older. Time of day too, we have circadian rhythms, diurnal cycles. We are meant to sleep at night. Okay, so some of our hormones, we have more of them at night than we do during the day. So late in the day and early night, we have high amounts of growth hormone, and then it's lower during the daytime. I put this little picture just because I swear, I know one of my sons, I put him in his PJs, and I swore he grew overnight because it was really hard to get those PJs off in the morning. Okay, he just grew. 2, nutrient levels. If somebody doesn't have nutrients to grow, they're not going to have as much growth hormone release because there's no point, right? You don't have the building blocks to make body tissues. 2, stress and exercise, so physical stress also causes release of growth hormone. So there's lots of targets for that. One of the main targets is going to be the liver. It causes the liver to release insulin-like growth factors. Actually, if they suspect somebody has low amounts of growth hormone, so a child is not on their growth chart or they're very, very small, they will look for insulin-like growth factors to see if there is a low amount of pituitary hormone, so growth hormone. That's how they'll measure it. Both growth hormone and insulin-like growth factors, they act synergistically and they do the same thing. The predominant targets are going to be bones, cartilage, skeletal muscle, okay, to get bigger in size. Other things too, since we're building, we're going to get some mitosis, we're going to get protein synthesis, but we also sort of need to fund our building project, right? So we need to get nutrients. And so the liver is going to release some glucose, the cells are going to take up amino acids so they can build proteins, and then it's a time to let's burn some fat because we need to grow. Okay, this is why, I don't know if you heard, it was Peyton Manning, I think, they did a big sports scan. Anyone follow sports? Okay, sorry, just talk to you then. No, just kidding. But growth hormone is abused in sports, and then also now it's like being packaged as the fountain of youth. Because who doesn't want more muscle and less fat? Right? Okay. So if there's an imbalance, you can be very large if there's too much, or you can be very small if there's too little. So it's called pituitary gigantism, so someone gets to be gigantic. The problem is you have too much blood sugar because you're funding this growth project if it's untreated. 2, the internal organs get to be a very large size. If it's not treated, it gets to be an early death. So usually they die 40s, not making it to the 70s. Pituitary dwarfism, also called growth hormone deficiency. A person has the proper proportions as an adult, they just have a shorter stature. And usually, like I said, because we have this chain of command, if there's too little, it could be a pituitary gland isn't making it, or it could be the hypothalamus. So when people have endocrine issues, sometimes it's hard to parse out where the problem is, because it could be here or here. Okay? So short stature and low blood sugar. So this is going to be obviously during the growing years, so during childhood. What can happen though is somebody grows, because growth hormone determines basically the maximum size a person can attain. Okay, once, if you guys remember from skeletal, your growth plates, epiphyseal plates, once they close, you cannot increase in stature. So a person is an adult, and now they have a hypothalamic or pituitary tumor, and they have too much growth hormone being released. The body cannot get any taller, but it can grow apositionally, so just wider, thicken. So enlargement of the bones, face, hands, and feet, and that's how it got the name acromegaly. So mega means big, big appendages. So the hands and the feet particularly increase in size, and you can kind of see the progression of this woman. Also, too, you get a release of glucose. The internal organs are going to grow. Really what's going to get your patient to come in is they're going to start, they may kind of notice the physical changes, but their bones are going to hurt. So that's going to get them in there. So we get this loss of feedback control, because normally if the hypothalamus tells pituitary to make growth hormone, pituitary gland makes growth hormone, then it should stop saying make growth hormone. And so there's just an imbalance somewhere on the chain, and you get it as an adult. So go ahead and color your anterior pituitary and attach it to all this up here. And so that anterior pituitary, as the first mate, is going to send out the orders to the other endocrine glands through the way of tropic hormones. It's an old version. Go with tropic hormones. So FSH and LH, these are gonadotropins. We're going to get egg in females, sperm in males, and then the sex hormones. And like I said, we'll cover that thoroughly in Unit 5. Adrenocorticotropic hormone, we're going to talk about that one in just a few minutes. That's going to talk to the adrenal cortex. Thyroid stimulating hormone is going to stimulate the thyroid gland. We'll talk about that one shortly. Prolactin, we'll talk about it in Unit 5, but if we take that word apart, if I'm pro something, I'm for it. In this case, we're for lactation. So prolactin is for milk production after a woman has delivered. Growth hormone, primary targets, skeletal, bones, and muscles. Too little as a child, pituitary dwarfism. Too much as a child, so hypersecretion, gigantism. Too much as an adult, acromegaly. So the thyroid gland, it is in the anterior neck. It wraps around the trachea. It is butterfly shaped. We looked at it in lab. So they're filled of thyroid follicles. So each one of these is a follicle, the whole thing. We have follicular cells that are going to make thyroid hormone that's stored in the colloids. We kind of learned that already. The parafollicular cells are going to make calcitonin. So thyroid hormone, there's really two hormones that are made. It's T4 and T3, and the numbers have to do with how many iodine molecules are attached to them. T4 is called thyroxine. More of it is produced. It is less active than T3, but it's going to be converted to T3 at the target, so that's really not an issue. T3 is triiodothyronine. Less of it's produced, but it's the more active form. Remember, this is the weirdo I want you to remember. It's a modified amino acid, so made from tyrosine, but it is lipid soluble, and so it's going to act by direct gene activation. The thyroid gland is the only gland in the body that uses iodine, so that's unique about it. That's why we have to have iodine in the diet. And then it's the only gland that stores 2 to 3 months worth of its hormone as colloid. So it kind of stores it for later. And don't forget, thyroid hormone needs a carrier in the bloodstream. All right, let's look at its regulation.
Within the base of the forebrain is the hypothalamus, a region of the brain that integrates information from the rest of the body and regulates most of the body's endocrine systems. An example of an endocrine system regulated by the hypothalamus is the hypothalamo-pituitary axis. Some neurons within the hypothalamus produce and secrete thyrotropin-releasing hormone, TRH. TRH is secreted into the hypothalamo-hypophyseal portal vessels and carried into the anterior lobe of the pituitary gland, where it stimulates cells that make thyroid-stimulating hormone, TSH. TRH stimulates the release of TSH from the anterior lobe of the pituitary. TSH enters the bloodstream and is carried to the thyroid gland. At the thyroid gland, TSH stimulates the production and release of thyroxine, a hormone that regulates the metabolic rate of all the cells in the body. In addition to regulating our metabolic rate, thyroxine inhibits the TRH-containing neurons within the hypothalamus. This inhibition results in decreased release of TRH, and thus a decrease in secretion of TSH and thyroxine. This is called a negative feedback loop, and occurs frequently in the endocrine system.
Okay, so we've got the hypothalamus is going to talk to the pituitary gland, the anterior pituitary, which is going to talk to the thyroid gland. The things that cause release of thyroid hormone are, one, cold temperatures, because we're going to get heat production from thyroid hormones. Pregnancy, somebody needs to increase their metabolism because they're building a human. High altitude, hypoglycemia, so low blood sugar, And then low thyroid hormone because it's all through negative feedback. So we have releasing hormones, so thyrotropin releasing hormone. And like I said, they name these well. So it's just the hypothalamus talking to the anterior pituitary, hey, release that thyrotropin that's going to get the thyroid gland going. And so that's just what it's saying. Pituitary gland, first mate goes I, captain, releases TSH, thyroid stimulating hormone. What do you think that's going to do? Don't you like the names? Okay, at least they name them something that makes sense. They don't always do that, but at least they did that. Okay, then the thyroid gland, if it's functioning, it's going to go I. Okay, captain, so T3, T4, likely we're just going to say thyroid hormones.
So it releases both T3 and T4?
Correct. The target for these is pretty much all of your cells. Okay, so it has a really widespread effect. Okay, everybody. It's going to increase metabolic rate, so say it's going to talk to the neurons in particular. It is necessary for neurological development in childhood, and then also just for neural functioning as an adult. 2, it's just going to increase the amount of sugar that's burned and the amount of oxygen used and the amount of energy made. So the way we say that is it's going to increase the basal metabolic rate. Basal, you see the word base in it, so think baseline. How much energy does your body use just sitting there, like doing nothing, like just sort of maintaining you? So fosters ATP production, that's that universal currency of energy. So we're going to burn some sugars, we're going to burn some glucose, use some oxygen, and generate heat. Whenever we break down our fuel, we create heat, so it causes heat production, which is called the calorogenic effect. If we are burning our fuel, we are going to be breaking down some fats. Also, it has an effect on respiration because we need more oxygen, so increased breathing rate. It has an effect on the heart rate as well. It's going to increase heart rate and force of contraction, so it kind of speeds everything up. If you have too much of it, just kind of think, what do you think is going to happen? Is somebody going to be a skinnier person or a fatter person? Skinny, yeah. Just up that metabolism, all right? Are they going to be calm or twitchy? Twitchy, hyperactive, all right? And then as far as their temperature, are they going to be cold or warm? Hot. There you go, see? So you got it. So those are the clinical signs of hyperthyroidism. This woman has full-blown hyperthyroidism, so Graves' disease. It is an autoimmune disorder where the antibodies bind to the receptor for TSH and turn on that thyroid gland. Just get it going. So that's the number one cause. It can be a loss of control because what's supposed to happen, right, is hypothalamus talks to the first mate through thyrotropin releasing hormones, TRH. Anterior pituitary goes I, captain, releases TSH, and then thyroid gland, if it's functioning, makes thyroid hormones. If it's doing its job, this is going to turn off the release of TSH and TRH, right? Because yes, I did my job, and they're both looking to see if the thyroid gland did its job. And if it did, it should shut it down. But like I said, if the problem's here and this negative feedback isn't working and it still releases TRH, anterior pituitary is going, okay, more TSH, more thyroid hormones. Or it could be here, this negative feedback's not working. Okay, and it's just still just releasing it, so it's gone rogue. Okay, and it shouldn't be. So you can get imbalances that way. Also, when somebody has hyperthyroidism, usually they'll have to remove the thyroid gland or they'll use radioactive iodine or something, but then that person now has to take thyroid hormone. They might be taking too much. Other things you get, notice this young woman, she has a goiter. We'll talk about that in a second. So this is enlarged because it's overactive. But what do you see with her eyes? They're also protruding, so exophthalmos. They call it when they're together exophthalmos goiter. So there's fluid behind her eyes that's pushing her eyes forward. Yeah, so that's hyperthyroidism. So now go opposite. Now if you have too little, so skinnier, bigger, bigger, okay. Twitchy or sluggish, okay. Hot or cold. There you go. Okay, so it comes with a mental sluggishness. Once they start taking thyroid hormone, that will come back. Okay, the number one cause in the United States is Hashimoto's thyroiditis. It is also autoimmune. Globally, though, the number one cause is going to be iodine deficiency. We've got iodized salt and things like that, and most people have access to different foods from all over. Once again, it could be loss of stimulation. The pituitary gland's not giving the signal. Hypothalamus isn't giving the signal. Okay, and then 2, once it's been removed, so surgically, you can also get it. And then when we looked at permissiveness, so neonatal hypothyroidism, I showed you a young little boy of short stature. Okay, so I just cut through that one in there. We kind of looked at that already. So someone needs to have thyroid hormone replacement. The name for that, or the condition, so if you look at this man down here, what do you notice about his face? It's kind of puffy. Yeah, so the name for it is mixed edema, just means tissue swelling. So people just kind of get a puffy appearance, their skin's kind of dry, and they'll be slow, kind of moving. I had my best friend in high school, my brother called her the sloth. Not a nice name, but it's a brother, right? Okay, she was slow moving. She swam on the swim team, which is amazing. She was a great swimmer, but she moved slow. She was tired. She talked slow. Turned out she had hypothyroidism. So goiters is when the thyroid gland is enlarged. You can get that with hyperthyroidism or hypothyroidism. If there's an iodine deficiency, the thyroid gland, we got the hypothalamus, pituitary gland, the thyroid gland's trying to do its job, so it starts to build it, but it can't finish the project. So it just starts accumulating unfinished thyroid hormone because it needs that iodine attached to it, and just starts accumulating. So you see goiters were very common prior to iodized salt. Anytime, though, there's an overproduction of thyroid hormone, you're going to get the goiter. Or if you can have thyroiditis, so Hashimoto's thyroiditis, itis means inflammation, it can also get large. If TSH is high, you can still get a goiter with hypothyroidism. So either way, it can be overactive, like in Graves' disease, like you're just making too much, or under. So pre-1920s, about 70% of children had a goiter. It was so common. This part of the country was called the goiter belt. They even had jewelry designed goiter necklaces, so it would just hang right there and just kind of, mask your goiter. It was that common. Okay, so still globally, it is a significant health issue. So where it's really dark purple, that is risk of moderate iodine deficiency. And then the purples. And then when you get to the gray area, now if you have too much iodine in your diet, you can actually cause a hyperthyroidism. So, gotta balance that. The other hormone that is made is calcitonin. Calcitonin tones your bones. Did you guys learn about calcitonin when you did skeletal? Mm-hmm. Okay, so it causes calcium to be placed into bone. So it's going to reduce osteoclasts. Clasts are the bone crushers. Kidneys are going to get rid of calcium in the urine and then tells it's time to build bone. It isn't really a big player in adults, to be honest. If somebody has their thyroid gland removed, they don't replace the calcitonin. Number one controller is going to be parathyroid hormone. So let's go ahead and color your thyroid glands. All right, so thyroid hormones, number one in controlling our basal metabolic rate, how much fuel you burn, how much sugar you burn, how much oxygen you use. It requires iodine. It is lipid soluble, even though it's a modified amino acid hormone. Sorry, modified amino acid hormone. 2 to 3 months worth is stored. Hypersecretion, Graves' disease. Hyposecretion in an adult is called myxedema. And then I wrote neonatal hypothyroidism. I didn't change my PowerPoint, so don't worry about that. The not nice name for that is cretinism. It wasn't worth making a new slide. Sorry. Had a lot to do. You can get a goiter, an enlarged thyroid gland, with either hypersecretion or hyposecretion. Calcitonin is also released, and that lowers blood calcium levels. All right, so the parathyroid glands, because like I said, it's good to memorize these in antagonistic pairs. So calcitonin lowers blood calcium, parathyroid gland raises it. So the parathyroid glands, para means alongside, like two parallel lines are next to each other. They are on the posterior, the back side of the thyroid gland. And to be honest, people are variable in this. Like I said, I did a dissection last summer in Colorado. And I was like, I want to dig for some the parathyroid glands. And so we had a couple of cadavers, and they were in different places. Usually the superior ones, they're right where they should be. These two are kind of wanderers, and they can be anywhere, actually, in the neck. But anyway, so it's variable. They have chief cells and oxyphil cells. Don't really care about those. But the chief cells are the ones that are going to make parathyroid hormone. So parathyroid glands make parathyroid hormone. It is going to increase calcium levels. We care about calcium because our neurons can't fire without them, our muscles can't contract without calcium, our blood can't clot. So kind of big, important things. So we regulate calcium tightly. There's going to be 3 targets and 3 mechanisms to raise our blood calcium. One, we are going to stimulate those osteoclasts, because this is where we store our calcium. If we're not getting it in our diet, we'll take it from the bones. So it's going to release calcium. Kidneys, it's going to tell the kidneys filter blood and make urine. Say, hey, if there's any calcium at all, don't pee it out. We need that, so reabsorb calcium. And then also, it's going to stimulate calcitriol, and the hormone for absorption of calcium. Hey, whatever calcium we have in the diet, make sure we get all of it, because we are calcium poor right now. Okay? So that's going to restore homeostasis. It's the #1 regulator of calcium levels. And it's going to pretty much work through negative feedback more so than the calcitonin parathyroid hormone. So if calcium's fine, no parathyroid hormone released. Calcium goes down, parathyroid hormone gets released. All right, so there's the parathyroid glands on the back. So it's kind of showing you the back side. So if you need to write posterior or back, so you know that. The parathyroid hormone, #1 calcium controller, raises blood calcium, decreases bone mass. So turns on those osteoclasts, so the bone crushers. Increases absorption from diet, calcitriol, and decreases loss in the urine, so the target is the kidneys. And we'll talk about the imbalances. I kind of left this on. This is more for after we do our balance units. But yes, you can have imbalances. So it can be too low, so you have hypocalcemia, or it can be too high, hyperparathyroidism, hypercalcemia. And it has an opposite effect on our neuromuscular functioning. So if you have too little calcium, you're too twitchy. If you have too much, then you are weak and non-excitable. All right, how are we doing? I'm going to kind of push you because we have a big lab today. So we're going to wrap up stress. Look you up though. To the good old days when the mama sang us to sleep, but now we're stressed out. All right, let's talk stress response. All right, so the adrenal glands are responsible for both our short-term and our long-term stress response. That adrenal medulla, we know, is innervated. And when we get a fight or flight situation, sympathetic nervous system, action potential, release of norepinephrine and epinephrine. So adrenaline and noradrenaline. It has a longer effect when it's released as a hormone than it does when it's released at a synapse. The adrenal cortex we looked at in lab and we saw the 3 layers. So there's 3 different types of hormones made from the adrenal cortex. Mineralocorticoids, and it's telling you it's a steroid hormone from the adrenal cortex that has to do with minerals. If you're a picture person, here's your picture. So it has to do with our sodium and our potassium balance. Hormone we're going to talk about is aldosterone. Also makes glucocorticoids, so steroid hormone from the adrenal cortex that has to do with glucose metabolism. So we're talking about our sugar levels, so cortisol. Gonatocorticoids, steroid from the adrenal cortex, has something to do with reproduction. And so we're going to get mostly androgens made. It's going to get converted to estrogen in females. The amount that's coming from the adrenal cortex is way less as far as androgens than what's made from the male testes. Okay, but there is some being made there. And we've looked at these different zones. So zona glomerulosa, we are going to get aldosterone. Zona fasciculata, we get cortisol. And zona reticularis, we get the androgens. Oops. Oh, it didn't play. Come on.
The stress response. In stressful situations, the body switches on its autonomic nervous system and neurobiological processes in an attempt to maintain homeostasis. The body is prepared for its reaction to stress. In the brain, the hypothalamus is connected to the pituitary gland. The hypothalamus, stimulated by the sympathetic nervous system, releases the hormone corticotrophin-releasing factor, CRF. The CRF activates the pituitary gland to release the adrenocorticotropic hormone, ACTH. This in turn alerts the adrenal glands. The adrenal glands are located on top of each kidney. The ACTH from the pituitary gland stimulates the adrenal cortex to release cortisol. At the same time, neurons in the hypothalamus signal the medulla to release epinephrine, adrenaline, and norepinephrine, noradrenaline. These hormones then push the body into hyperalertness.
So we have our chain of command again. Okay, so in AP1, hopefully you learned about that really fast fight or flight response with supernatural strength, and that's due to that rush of adrenaline or epinephrine and norepinephrine, noradrenaline, so the catecholamines. So increased heart rate, blood pressure, bronchioles dilate, so you get that oxygen in there, whole release of glucose from the liver. Blood flow is going to be redirected to the heart, the lungs, the muscles, because you are either going to run from a bear or fight a bear, depending upon what it is. So metabolic rate increases. Also, what's going to happen, the hypothalamus is going to go, hey, we've got some stress. Okay, so it is going to send its message as it talks to the anterior pituitary, so corticotropin. So for the cortex, we need the tropin that's going to get the adrenal cortex going, releasing hormone. captain. So anterior pituitary releases ACTH, adreno. I wrote it over here. So adrenal gland, cortico, we're talking chest of the cortex because the medulla is different. Tropic hormone, hey adrenal cortex move. The adrenal cortex gets the message and it's going to make 2 hormones. Predominantly our stress hormone is cortisol, which is a glucocorticoid. So we're going to get what we want from this. What's in the word?
Glucose.
Glucose. Sugar, right. So we need sugar to make ATP to get out of our situation. Okay? How we're going to get that glucose is we are going to break down some proteins and burn some fats. When we are in a stressful situation, it's like energy dump. Energy dump, we'll fix it later. Okay? So blood glucose increases. Also, it suppresses the immune system, particularly inflammation. Have you ever heard of people that they're in this fight or flight or they're in a stressful response and they have to pull people out of a burning building or something? It's kind of good if you are either fighting or you're trying to save somebody. Ow, that hurts! Right? It's no time for pain then. Okay, so that's kind of like, let's just shut that down right now. Okay, so that way we're better at getting out of our issue. Net effect, we're going to get increase of all nutrient molecules in the blood. The other hormone that can be released is aldosterone, and that's a mineral corticoid. We'll look at that at a different slide. So let's look at aldosterone. You're going to see aldosterone, at least 2-3 more times. So as far as stress, or this part of our diagram, stress, hypothalamus, corticotropin releasing hormone, adrenocorticotropic hormone from the anterior pituitary. Now we're going to get the zona glomerulosa is going to release aldosterone. The target is the kidneys. Kidneys filter blood and make what? Urine. Okay, so we're going to control that. What we want to do in this case is we are going to reabsorb sodium. Sodium and chloride makes what?
Sodium chloride, which is salt.
Salt. Yep. So we're salt. Water always follows salt. Okay, so I have my cute little picture here. So here's salt, and it's walking water like a little dog. Okay, so wherever the sodium goes, water goes. So now we're reabsorbing sodium, we're reabsorbing water, we're going to raise blood pressure because we're going to increase blood volume. We're going to get rid of potassium. So it's a mineral corticoid, we're going to reabsorb sodium, get rid of potassium. What we're going to get from this increased blood pressure and increased blood volume. The idea behind this is if we are in a stressful situation, some people, their blood pressure goes up when they're stressed, to kind of maybe remember it that way. But blood pressure allows us to deliver nutrients and oxygen to the body. Like, so don't think about it like bad, like hypertension. Just, you need some blood pressure to deliver.
Does the hypothalamus connect with this specific cortisol with if your body goes into shock, it sends something to the hypothalamus? Because I know a lot of people, when they're in shock, they don't feel any pain. So
Oh, absolutely,
okay.
yeah. We'll talk a little bit about shock in the next unit,
Okay.
and maybe another unit. Absolutely, that is a just save your life.
Okay.
It is
that
screaming.
Fight or flight type of.
Everything.
Okay.
Epinephrine, norepinephrine, cortisol, screaming.
Okay.
Everything. Yeah. So, like I said, the function of cortisol, there's a whole lot of chatter about cortisol. It causes belly fat and everything else. A normal amount of cortisol is a good thing. Okay, we have to have cortisol. It helps us resist stress, for repair. Don't think just I'm stressed out. Think, injury, sickness, other things like that. The net effect, yes, it does suppress the immune system when we use that clinically. So if you ever use cortisol, hydrocortisone, prednisone, any of those medicines, they suppress the immune system. But what we want is we're going to get a whole lot of glucose because we need glucose as energy. Okay? So if we got energy, then we can fix things, we can repair things, we can, get out of our problem, think our way out, fight our way out, whatever we need to do. Usually what's going to happen is called glucose sparing. Your brain likes glucose, despite what the keto diet says. I get it. But your brain likes glucose. So it gets glucose first, and other tissues will start using other things. Burn fat, break down some proteins, whatever that takes. And so, too, also if you're in a stressful situation, we're not going to be building at that moment. Like I said, usually these levels are controlled, things are good, and then you recover. It's when you get to the exhaustion phase of stress, that's when it gets bad and bad for your health. Okay, so it's a normal response. This is a great picture to study from. I can't teach from, it's too many words and it's too small. But I put that in there just, if you don't have a textbook, it's a nice picture. So if you have a problem, so an imbalance, if there's too much secretion from the adrenal cortex, it's called Cushing's syndrome or disease. If it's due to drugs that someone's taking, so if they have an autoimmune disease and they're being prescribed cortisol or versions of that, then it's a syndrome. If it's due to an imbalance somewhere along the chain, then it's called the disease. So this is a picture of a classic full-blown Cushing syndrome. And keep in mind your patients could just be a little bit hypersecretion or a lot. So this is like full-blown, what could you see? And then there's a summation slide, by the way, so just hang on with me. You can kind of see there's more, yes, there is more belly fat. So a redistribution of fat to the center. Also, strangely enough, there's a fat pad. It's called a buffalo hump. It's not the best name, but that's what it's called. So a fat pad, you kind of see that. To increase blood pressure, right? So if we get a little too much aldosterone in there. Hyperglycemia, if it's a female, menstrual irregularities. Can also see some excessive hair growth. And then kidney stones or other things. Causes, chronic corticosteroids if they're on therapy, or the adrenal gland is making too much. If this is too high, it's going to make too much. Okay, so an imbalance. So treatments discontinue drugs or remove a tumor. The opposite, yes, look at John F. Kennedy had Addison's disease, or Addison disease. It is adrenal insufficiency. Usually this is autoimmune. Another hormone that's made by the adrenal cortex is melanocyte stimulating factor. And so people have what's called bronzing. And this isn't all over tan. There's no tan lines with this. Okay, and so he was known for his, he always had a tan. He looked good. They did a lot of work. This was before cell phones and you could record things. They kept a really good secret because it's very hard to regulate. You have to figure out how much cortisol does that person need. It was a little stressful being president, so he had a fleet of doctors making sure that his cortisol levels were okay to help him do his job. So weight loss, fatigue, weakness, you pretty much just feel like crap from what I understand. Low blood glucose levels and low blood pressure. So the adrenal gland fails, chronic shortage, like I said, can be a problem. This is too little, so you're not getting that stimulation. So they have to take it orally. It's a steroid, they can take it orally. Other hormones made by the adrenal cortex, remember, are male sex hormones predominantly. So there's a couple things that can happen. If you have too much secretion, if it is a female fetus in utero, this can happen, and we'll learn more about this in Unit 5, because we'll talk about how you get your sexual organ development, okay? But if there's any testosterone, you get a male. You get male reproductive parts. So if the adrenal cortex in a female fetus starts cranking out testosterone, you're going to start to get male parts. And so it's called adrenogenital syndrome. And so imagine if you, back in the day, they know about this now, but think back in the day, someone hands you this. What are you going to say? Girl, boy? Yes, right? Okay, and so this has happened, and so usually people, they just pick one.
Is that intersex?
Yes, exactly. So they just kind of pick one and go with it. And there's thousands of people walking around that are intersex and have sort of a ambiguous genitalia. We'll talk exactly how that happens in Unit 5, but I'm just saying that can be from adrenal genital syndrome, too much male hormones from the adrenal cortex in a female fetus. And so, treatment's just acceptance. You say, okay, these are the parts I have, that's fine. Corrective surgery or steroids. It can also cause hirsutism so male pattern hair growth in women. Please do not walk up to a woman with facial hair and go, hey, I'm an AP2, I know what's wrong with you, because that can be caused by other things too, okay? Just saying. Yeah. All right, so just kind of recap on the adrenal cortex. Oversecretion, so hypersecretion, you get Cushing's syndrome. So excessive glucocorticoids in particular. Okay, so hyperglycemia, obesity, frequent infections too, because you're suppressing the immune system and you get that sort of moon face, buffalo hump, and redistribution. Adrenogenital syndrome begins in utero, so masculinization of female newborn. Too low, so the opposite is Addison's disease. So insufficiency of the glucocorticoids, sometimes mineralocorticoids, so low blood sugar, low blood pressure, fatigue, weakness, and the bronzing is kind of a big clue. Someone's usually very pale, like it's all over. All right, so go ahead. Now there's two parts I want you to know. So color your adrenal cortex one color. So the cortex is the part around the outside. So I use the dark purple. You can do whatever color you want to. So the part around the outside, that is the cortex. So I just color-coded mine with the darker color. And then I did the middle a lighter pink. Just kind of make sure you know your medulla from your cortex. And remember, the medulla is that short-term alarm reaction, stress response, epinephrine, norepinephrine. And then the cortex is, you get cortisol, which is a glucocorticoid. You get aldosterone, which is a mineralocorticoid. And then you also get androgens. Andro means male, so male sex hormones. Male sex hormones in females, they believe is responsible for libido, so drive for sex, has a role in puberty, and then also chest, pubic hair, axillary hair growth, male pattern hair growth. Cortisol increases blood glucose levels and suppresses the immune system. Aldosterone increases sodium decreases potassium. If you don't know, K is potassium. If you know that, you get water absorption and increase in blood pressure. Too much is Cushing's syndrome. Too little is Addison's disease. So our last, let's see, what do we do? I'm gonna let you guys watch this one on your own. I just want to finish your picture, and then you'll have your 10 minutes. So the pineal gland, did you guys talk about the pineal gland in AP1? A little bit. There's not that much to say, I'll be honest. That's a 2-minute video. You guys can watch that. It secretes melatonin. Some of you may take melatonin to help you fall asleep. It secretes it at night, basically when the sun goes down. It is a modified amine hormone. It's made from tryptophan. It is actually inhibited by blue light, so a lot of our screens, so your iPad, if your phone, or your TV, if you have like plasma or what is it? What's the flat screen? The new one, the one everyone has. What is it? TVs. I'll think of it later. Thank you. LED lights. God, it just wasn't coming. LED lights. That actually, the blue wavelength of light stops secretion of melatonin. So if you have a hard time falling asleep, then turn your stuff off at least 30 minutes before you want to go to bed. Okay. But anyway, it causes drowsiness. It's part of it. Just helps set our sleep-wake cycle. And like I said, it's linked to our eyes. So that's why we are kind of made to go to sleep when it gets dark, and I get it. I have night people in my life, so we don't need to have that discussion. But that's just the way it's supposed to work. It also has some role in reproduction. It releases gonadotropin-releasing hormone. So let's go ahead, and there it is. It's just this tiny little dot right here. So go ahead and color that. Attach it to the pineal gland. So it secretes melatonin at night, involved in our diurnal cycles, circadian rhythms. That's why we're supposed to sleep when the sun goes down. And so it kind of messes with people when they change time zones. As far as changes with aging, everything the body's supposed to do, it slowly stops doing as people age. So reduced efficiency, decreased levels, particularly growth hormone and sex hormones. All right, let's just kind of finish off our picture. This is the thymus gland. So just kind of color it, attach it. It has a role in immunity. It's where our T lymphocytes are mature, or immune fighters. The kidneys, their main function is to filter blood and make urine, but they also release erythropoietin, which we're going to talk about. I won't see you till Wednesday because Labor Day. So increases red blood cell production. We'll learn about it when we talk more about blood. We're just coloring it right now. And then we have the pancreas. Pancreas controls blood glucose levels. Insulin lowers the blood sugar after a meal, and glucagon is released when the glucose is gone and restores homeostasis by increasing blood sugar. And glucagon and epinephrine had that synergistic effect. Then we have the testes, make testosterone in males. and then ovaries in females. You can finish up your picture and take your 10-minute break. And then we'll have lab. Okay, so now it hit it and I don't know where it is.
If you go, try click that up arrow down. Which, is it one of those? There you go.
Thank you.